Good evening, everyone, and welcome to today's masterclass. We thank you so very much for taking time out of your schedule today to join us. We are expecting a very full house this evening, and so we're just going to go over a little bit of housekeeping as we get started. Typically, our masterclasses last roughly around 45 minutes, so that's going to be our target for today. In terms of questions, we love to make these sessions as interactive as we possibly can. And so please write in using the chat window within Zoom if you have questions. If you are a provider on the call and you've seen things in clinic or have comments that you would like us to share, please write in through the chat window. Again, we want to make this interactive so that it's not just us talking to you. We are expecting today a mix actually of both patients and providers. And so we're going to do our best to touch on both audiences and topics that are of interest to both groups of people. And I want to just mention that this event is hosted by Alterra Health, and we have the leading platform for education and support for obesity medicine patients and providers. And we host these events, usually 2 per week. And so if you're interested in learning more about these events and what we do, you can email us, and I'll make sure that one of us puts our email addresses in the chat window here. Just going through my notes, I see some more people are joining. So we talked about the session link, the events, and I'm joined tonight by Whitney Gibson, the co-founder of Alterra Health. Whitney's feeling a little bit under the weather, so we're going to tag team this a bit because I know she's having a bit of trouble with her voice. So Whitney is going to discuss nutrition. She's a registered dietitian and is going to tackle those topics. And then we're also joined by Dr. Leon Katz. And it is an absolute privilege to have Dr. Katz with us this evening. And the topic for our session is menopause, and specifically menopause as it relates to weight gain, hormones, and what all of that looks like. So just a little bit of background on Dr. Katz. So, Dr. Katz has been practicing obesity medicine for over 20 years. And prior to launching his own practice, he was the director of medical weight loss at New York Bariatric Group, where he developed a comprehensive program integrating both bariatric, surgical weight loss, and medical weight loss. And at this point, Dr. Katz has worked with professional spanning many different disciplines in healthcare and has helped thousands and thousands of patients. And when he takes over, I'll let Dr. Katz explain a little bit more about his background, but we are just so honored to have him with us tonight. And if you're interested in learning more information about Dr. Katz, you can visit his website. It's drkatzweightloss.com. He's also active on X, LinkedIn, YouTube, and he publishes regularly for obesity help as well. So for more information about Dr. Katz, that's how to find it out. I see we might have had a couple more people join. So again, we want to make this interactive. Please write into the chat. We'll include our email addresses if you have questions. And with that, let's go ahead and get started. And Whitney, if you would mind starting us off with nutrition and nutrition as it relates to menopause, please.
Yeah, so I know there's a few questions that we have coming in ahead of time. Um, a couple of those that are related to menopause symptoms specifically. So we'll talk just 2 questions about nutrition quickly, and then we'll move on to Dr. Katz. So one question that is very common is what dietary changes can help manage menopause symptoms like hot flashes, bloating, bone health. So when we're talking specifically hot flashes, you can think, well, what are things that typically might make us hot? So drinking alcohol, it heats up the body. Caffeine, it speeds up the system. And of course, spicy foods. So adding more foods like soy-based foods like tofu or edamame, those are for natural phytoestrogens. So those are really good additions. Also bloating. So when it comes to fighting bloating, we want to limit higher sodium processed foods. You can also increase fiber, but one of the main things we don't think about whenever we're telling people to increase their fiber is to specifically increase your fluid. So I make a little rule with my patients and members and saying, when you increase fiber, you increase fluid. Fiber needs fluid. So increasing the intake of fruits, vegetables, whole grains, just basically higher fiber carbohydrates, and then also additionally matching that with good adequate hydration. And then bone health. So it's hard to get people to care about bone health until it's an actual problem. But we can speak a little bit more to calcium rich products such as dairy, leafy greens, and also fortified plant milk. So almond milks, um, soy milk, you're going to see the fortified calcium or calcium fortified products there as well. And in addition to vitamin D. So where we can get vitamin D's, more so fatty fish, eggs, and sunlight. We don't talk enough about sunlight. Everybody's scared of the sun. Everybody wants to slather themselves in sunscreen, but minimal 15 to 20 minutes a day in the sun. And that's really going to help bone health as well. So, are there specific foods or nutrients that you should focus on during that transitional phase or during menopause? Overall, my diet recommendations will always, always, always go to fighting inflammation. So, if we can aim for a balanced diet rich in omega 3s, so these are foods like ground flaxseed, chia seeds, walnuts, salmon, antioxidant rich foods like berries, leafy greens. These are all going to contribute to fighting inflammation. If we were to sum it up in a nutshell, it would be more of a plant forward diet. So I don't want to totally make everybody start eating a bunch of plants. A lot of times people think of the word vegan or vegetarian and it becomes a little bit unapproachable, I would say. So if we can kind of just get our patients to or if you are a patient listening, to include more plant forward foods into your diet, as much color as possible in the areas of fruits, vegetables. And if we were to actually put a label on what type of diet, if I were to look up a diet, what would that look like? And Mediterranean diet really reflects high omega-3 content and anti-inflammatory properties.
Thank you so much, Whitney, for going over that. For everyone just joining, again, we want to make this interactive. So please write in with questions, comments. If you're a provider, maybe something you've seen in clinic. And again, for people just joining, we host these twice a week. And so if you'd like to know more information, we're happy to help you. Dr. Katz, let's turn it over to you, please. And we would like to start with the first topic of sleep. And so sleep disturbances are common during menopause. Can you talk to us about what that looks like and how you can improve your sleep quality during this time?
Yes, so thank you. Really a pleasure to be here tonight. So when it comes to the combination of the word postmenopausal and sleep disorder, there are a couple ways to think about it. So let's take, and we're going to utilize also obesity. So there are multiple factors going on. So in general, a woman that enters menopause, about 60% of the time, these women experience some degree of a sleep disorder. That's compared to about 30% in women that are premenopausal. So by definition, getting older comes with having poorer sleep. That's number one. Number two, there's a question of some of the hormones, and I'm not talking about the estrogen or some of the sex-related hormones, but good old-fashioned melatonin. So melatonin also seems to change and is diminished, but also not secreted appropriately when a woman enters menopause. So that's a concern. Now, the question is how does one get diagnosed properly and how does one get the necessary treatment? So the easy answer, which is not the best answer, is the use of medication. So my recommendation is, which I hope is practical, you don't be your own doctor. It's hard enough for us as doctors who are not sleep specialists to diagnose it. But if you're really suffering with sleep-related issues, don't pretend or think that somehow it's your fault or you're doing something or you're not doing anything wrong. You would benefit from seeing a sleep specialist so they can do a workup. There are many, many causes of women having difficulty falling asleep. So the important thing is some of them may indeed benefit from medication, and the classic medications are like benzodiazepines. And so those medications are the best option, but for a specific group of women, not for everybody. Then the next question becomes what can be done on a purely practical manner and not necessarily medication? Well, for one thing, number one, the urinary system. It's not just the guys that have issues with the prostate and have to go get up 5 times a night. Apparently, our ladies that don't have a prostate, but because of the loosening of the pelvic floor, the shape and angle of the bladder, women also have to wake up multiple times to go to the restroom. That, in and of itself, is going to present a problem with quality sleep. And then the real challenge is not only waking up to go to the bathroom, but then falling back asleep. So that's an issue. Solution. If at all possible, do most of your drinking of fluids in the first half of the day, and then just to drink less towards the evening or a few hours before the night to diminish that. That certainly is not going to hurt, and it may help. That's number one. Number two, consider also uh, for women going through the vasomotor changes. So, for example, the hot flashes, all that. Hey, you know what? A fan is a fan, and it's near you and you might as well use it. You have a fan from the ceiling or on the side, might as well use it. It will help you for those few seconds, a few minutes. And so that's just practical advice. So that's number two. And then here's just really good advice for anybody. Could be a man, woman, doesn't matter the age. Good old fashioned, as we call it, like a sleep hygiene. Plain English. Make sure that your bedroom is exactly what it sounds like. It's your bedroom. It's not your dining room. Don't have your dinners in your bedroom. It's certainly not your lounge or your family room. So, as best as you can, if your bedroom is where you know you go and you sleep, that would definitely be useful. You know yourself, there are some people that caffeine really affects them poorly and it's difficult to fall asleep. Then in that case, have your coffee in the morning. Try not to have it after a certain time of the day where you know you're going to be up all night. And the other thing that's really pertinent in this day and age, good old-fashioned social media, iPhones, iPads. You probably know, you should know, there's the night mode, and that's when the screen kind of looks almost a little bit brownish as opposed to the clear blue light. It's that blue light that will really interfere with melatonin and will make it difficult to fall asleep. So put that iPhone or whatever onto the sleep mode. And in ideal world, stop using that technology about an hour before going to sleep. Since everybody here is hopefully mature and honest, we know that we use it till the last 4 seconds before we go to bed. So at least use the night mode to diminish the negative effect of that blue light. So there you go.
Thank you, Dr. Katz. And for all of the patients on the call, I think that's a really, really good pointer is about using the night mode. I mean, it's something that seems possibly obvious, but a lot of people don't do it. And, they're using their phone super bright right up until the time of bed. And so that's a great point that you mentioned there. I just want to make sure before we move topics to hormones, are there any other like natural remedies or anything you want to cover, Dr. Katz, about when it comes to sleep and improving sleep
Right.
quality?
I would mention one more thing just
Sure.
now. This is for our women that entered menopause, perimenopause, and who are overweight. The issue of sleep apnea. That's a very legitimate issue. And while generally men tend to have more sleep apnea than women, but as women get older and the fat gets distributed more by the neck region, sleep apnea becomes more of a legitimate issue. So by seeing a sleep specialist, they will be more attuned. They'll know whether to send you for that test. If you have untreated sleep apnea, good luck taking your benzodiazepines or the warm bath or the warm shower. Good luck with that. Sorry, kitty cat's in the way. That's my physician assistant. So
I love it.
anyway, so the sleep apnea, until that gets addressed, then all the fancy stuff I just told you is not going to help. So just to keep in mind the sleep apnea.
Another great point. Thank you so much. And for the people joining, please, if you have questions, comments, don't hesitate to write in. Don't be shy. We don't want this to just be us talking. If we can, Dr. Katz, let's move to hormones. And if you'll start by just explaining generally, the hormone fluctuations that happen during menopause, and then, we can move into hormone replacement therapy and things like that.
Okay. So here we go, another class in and of itself. That just to dispel the myth, I think everybody kind of knows or says from the beginning, the word menopause equals decreased estrogen, and the conversation is ended right there, low estrogen. Like everything else in life, it's complex, but instead of turning this into a gynecological conference, there's something called estrogen, you all know. There's also progesterone, and there are two more hormones, just for you hear the names, FSH and LH. The bottom line is the estrogen is made by multiple areas in the body, but the main one in a woman premenopause is ovary. That's a given. The other hormones, the FSH/LH, are basically created and sent out from the pituitary gland in the brain. And it's a very coordinated dance. And so as a woman gets older, the follicles inside the ovaries, the follicles are limited. So when the young girl is born, there's a certain set number of follicles, and those kind of get used up. And that's why the famous expression that, oh, her ovaries are finished and all that, and that's why it's hard to get pregnant. Well, that carried through at a certain stage in life. The number of these follicles have diminished markedly, so there's less estrogen made. Then the portion of the brain that makes FSH/LH, that starts to shoot up because as far as the body's concerned, there's not enough estrogen. If we send a stronger signal, FSH/LH, if we send that stronger signal, then there will be more estrogen. That doesn't happen. So that's a little bit or more complete picture of what's happening hormone-wise. So the question then becomes, so how does one address that? My very first, and I think hopefully best advice is make sure you have your gynecologist involved. I'm a weight loss specialist. I understand the topic, but you need someone that more than understands it who actually treats it. So usually gynecologists, this is their training. They deal with this day in and day out. So make sure they're there every step of the way. That will definitely be very useful. In regards to the next question is hormone replacement. Is it worth it? What are the risks? What are the benefits? Obviously, my first comment is I'm not your doctor, so please understand this is general advice, not treatment advice. There's something called estrogen replacement therapy, just like it sounds like estrogen replacement. And then there's hormone replacement therapy, which is different. That's a combination of estrogen and progesterone. So those two treatments are different. When it comes to using these type of hormonal replacement therapies, they may not necessarily help a woman lose the weight, but if taken earlier on, it may diminish how much of the fat is deposited in the belly, known as visceral fat. You may know there's the good fat or okay fat called subcutaneous, which is under the skin and usually thought of as being around the hips, the buttocks, and that's usually not problematic in terms of getting metabolic syndrome. And then there's the fat in the belly called visceral fat. That one is far more of an issue and contributes to inflammation in the body. When it's around the heart, it contributes to heart disease. With all this said, use of hormone replacement therapy, if advised by your OBGYN, can definitely play a great role. It can also diminish markedly the symptoms associated with heading into menopause. The estrogen-based ones, they are good in terms of minimal cause of breast cancer per se, and also in a woman that has had a hysterectomy and there's no uterine lining to get overstimulated because what happens, estrogen stimulates the lining in the uterus. And if it's estrogen by itself, like estrogen replacement therapy, the lining of the uterus keeps getting stimulated. That's what can cause uterine cancer to appear. Hormone replacement therapy, which is a combination of estrogen and progesterone, that actually works well in women who still have their uterus because the estrogen is a stimulator, but progesterone cuts off the stimulation to the uterus. But the risk of that hormone replacement therapy, which is both estrogen and progesterone, is increased risk of breast cancer. So a really good doctor needs to take into account family history, your personal history, if there was any history of very early stage or precancerous breast lump. So those are the things that have to be evaluated in terms of whether this is a good option for you.
All great points. Thank you so much for going over that. And, for the patients on the call, kind of clarifying what they need to ask their provider first. What about natural ways to balance hormones, outside of medical intervention? Is there anything that you recommend, Dr. Katz?
I I have to be honest with you. I myself am not familiar with them. But there is an answer. There's a definite answer. This is when it comes to natural, one of the things to consider is there's nothing wrong with speaking to someone that knows alternative medicine, be it acupuncture. There's the Indian medicine like Ayurvedic, homeopathy. And so, you know what? When all is said and done, some of the herbs and Chinese medicine, all the medications we use today, and we call them pure medications, all that, majority started out as good old-fashioned herbs.
Mhm.
And they got manipulated and purified, and good old-fashioned penicillin. Our penicillin was somebody else's mold.
Mhm.
So when you think about, so look into other options in terms of control of the hormone. If you're told that official hormone replacement therapy is not a good option, certainly look at other options, but do your homework. Don't go with the garbage that you see on social media where they promise you for $100 a month guaranteed treatment for your postmenopause. Definitely not a good option.
Thank you for clarifying that. And I think at this point, let's shift gears into weight loss and menopause or weight gain and menopause. So, can you talk to us a little bit about why it's harder to lose weight during this period or tends to be more difficult?
Yes, so now we're up to the topic that's near and dear to my heart as a medical weight loss specialist. So there are a couple of things that are going on. Number one, the distribution of fat is changing. So instead of, let's say, premenopause, if a woman was gaining weight, a little bit went in the belly, visceral, but a lot of it went subcutaneous. So basically the fat that you could see with your own eyes. So that's part A. But as one enters the menopausal cycle, the fat is now preferentially being deposited in the visceral fat. So that's one part. In addition, there's loss of muscle. That happens to women and men. It's not specific to women, but in the case of a woman, it's more pronounced. And so a woman begins to lose the muscle, and net result is the metabolic rate diminishes. Now, metabolic rate can diminish all in its own as one gets older, but you add loss of muscle, now the metabolic rate is lower because one of the components of the metabolic rate is the amount of fat-free mass, otherwise known as muscle. So it's really, really crucial, ideally, for a woman to be engaging in any kind of resistance exercise. It doesn't really matter as long as it's safe. We don't want you to get hurt, but definitely use of resistance, a little bit of weights, consider working with a coach just to get you going in a safe way. That's number two. Now, this one, I had to look at the literature and kind of read it twice. When it comes to your calories you burn during the day or your total metabolic rate, total energy expenditure, there's energy that's expended by your body. It's called basal metabolic rate. Okay, that one can change and decrease a little bit. There's also something called non-exercised associated thermogenesis, or otherwise known as NEAT. So NEAT actually plays a big role in terms of the calories you burn. Think of it this way. You get up, you go to the store, you walk from here to there, you go up the stairs. That's an example of non-exercise energy, as opposed to the logical exercise, which is when you're physically exercising on purpose. As a woman enters menopause, that non-exercise associated activity, that markedly diminishes. Now, the good news is being aware that something like that is going on means that you have much better control over this than you may think. So if you, for example, park that car just a little bit further away and walk to that store, if you, for example, need to take an elevator to go to the fifth floor, nobody expects you to go 5 flights of stairs, even though it could be ideal. Why don't you just walk 1 flight and catch that elevator on floor number 2? These are the little tiny steps that together add up. So that's another thing. Now, the medication for weight loss, those actually work really, really well. As part of my practice, I don't think anybody would be surprised that women, usually between the ages of 45 and 60, make up a large part of my practice, and they're going through menopause. And interestingly enough, there are women that have been heavy their whole life. Menopause comes and they see changes in their weight. And then there are women who their weight has not changed much at all. The only difference they notice as they went to menopause is the distribution from their weight being average, their belly being nice and flat and all that. Now the belly is bigger. They feel like they just can't live in their skin. That is more classic of what we see. What I see, and I'm sure other clinicians who take care of people with obesity. So the weight loss medications actually work very well. Make sure you speak to your doctor. I find that those of us who do medical weight loss consistently, the advantage that we can offer, I know I work with an individual who's an expert in medical prior authorization for the medication. And that's a big difference because paying 25 or $50 copay versus $1,000 for the medication is basically night and day. So somebody that has that expertise can definitely change your trajectory in terms of medication use.
Please, if there's any questions, I mean, don't be shy, guys. I know there's some patients on the call. Please don't hesitate to write in if you have questions. In the meantime, we'll just continue going down the list that people have submitted before the session. So, what about Dr. Katz boosting metabolism and managing cravings during menopause? What do you recommend?
Okay, so boosting metabolism, here's the interesting thing. To the best of my knowledge, there are no official medications that are available that literally increase the speed of your metabolism. In spite of, like I said, the hocus pocus advertisements, especially on social media, that claim that if you take this, your metabolic rate will go up while you sleep, you magically lose weight. We've seen too many of those. There's no medication that will officially raise your metabolic rate. There may be a couple, including something called phentermine, that may raise your metabolic rate just a tiny bit because phentermine is more of a medication that acts in general in the body and increases, it's more like a stimulant. So like caffeine. But again, you can only take so much in terms of the dosage. I think what's much more practical is the more you can maintain your muscle, the more you can maintain your metabolism. The more you can build up the muscle, the faster your metabolism gets. So you have an option. If you're able to exercise, build up your muscle, you will increase your metabolic rate. If you're exercising and you're not building muscle, you're at least maintaining your metabolic rate. If you're not doing either of those and you enter menopause, well, it's pretty much guaranteed your metabolic rate is coming down. So, and what was the second portion, I'm sorry, of your
Just
question?
cravings. Anything you've seen around managing cravings or any recommendations?
Obviously, Whitney would be the expert. I will say from a medication point of view, this is useful to know. When it comes to cravings, this is fascinating to me. The same portion of the brain that controls cravings, it really doesn't care what it has a craving to. So, for example, a person that craves alcohol or drugs or gambling or food, the same portion of the brain lights up when they do a functional MRI. So the question is, well, what can you do about it? Obviously, one component is to look at it more from a psychological point of view. And so behavior modification, cognitive behavioral therapy. So that's one component. The medications that we use, especially the injectable GLP-1s, those actually studies are beginning to show that it's helping people to reduce the use of alcohol, to reduce use of some of the drugs. And while those have not been shown conclusively in studies, when it comes to food, there's no question that people's cravings are diminished and, in fact, they actually change. So, somebody that used to crave their ultra processed food or sweets and all that, that craving is markedly diminished. And my only conclusion is it has to do more with the neurotransmitters because it's like the person just started and 2 weeks later, they don't have the same cravings. So clearly nothing magical happened from a psychological perspective.
Thank you, Dr. Katz. And Whitney, would you mind putting our email addresses in the chat just so that if people have questions, um,
For some
they
reason,
can.
Austin, I cannot click anything on my screen.
Oh, okay. I'll put them in there. And then I think we have some literature as well that Dr. Katz is going to send at the end. So we'll put all of that in the chat window, our emails, and then any literature that we want to send. Let's for the final part of this session, can we move into well, I guess before that, we did get a question. So, Dr. Katz, how about those GLP-1 boosters? Supergut comes to mind that the usual suspects are peddling on Instagram. Can you talk to us a little bit about that? Any insight there?
Okay. So the concept of a GLP-1 booster, first and foremost, there's really no such thing. There's GLP-1, the hormone that does what it needs to do. But there's no such thing as something that comes in and causes the actual intestines to make increased GLP-1. So that's number one. Number two, GLP-1, the hormone itself in the body, the natural GLP-1 that is made by the intestinal tract, that has a half-life of about 2 minutes. So if a person takes a regular GLP-1 medication, well, GLP-1, if somebody injects it, like from a human being to another human being or in animals, it's out of the system in 2 minutes. It's the specific medications that have the GLP-1 with modifications of the structure. That's how it lasts for one full day. So medication like Saxenda, you had to take every day, or the Wegovy or Zepbound, which they last a week. But the whole boosting business, it's not realistic. It doesn't work. There's absolutely no literature for a simple reason. Who's gonna pay, like scientifically, who in the world will pay for that kind of a study? And I urge everyone in this call, take that money you have in on your debit card, whatever, please invest it in something useful. Do not donate to these charlatans. It's not gonna work. Now that's something you can take to the bank.
Does the same thing apply, Dr. Katz, for GLP-1 patches? Someone had a follow up about that.
Yeah,
Same thing.
yeah, great question. So there, I've seen a couple of new options available. So this starts this way. In the old days, when these medications first came out, the companies were able to deliver it to people. Then you have the whole issue with Ozempic on social media. Now everybody wants it, so the companies could not keep up with it. That's when the compounding pharmacies came out. And the compounding pharmacies were able to manufacture something similar to the real thing. There are issues there, it's not the same, but similar. Once these medications, like now, are being made by the original companies in adequate volumes, those compounding pharmacies, what they decided to do is they offer it in liquid form, under the tongue, pills, inhalation, transdermal. So, in other words, it's not the real deal, then it's not the real deal. So all these alternatives, and the other legitimate question, even if you're not getting hurt, which is the most important thing, you have no clue how much you're getting. And the answer, if you're not losing any weight, the company could always say, you know what, your body didn't react to it. They're never going to tell you, oh, you're getting 1/100th of what's required to lose weight. No one will ever tell you that. So please don't waste your money.
Thank you guys for writing in. It's always nice to make it, more interactive. So thank you guys for those questions. The last section of our presentation is around stress management. So Dr. Katz, if you could just talk to us about how menopause, this period, affects stress levels and any recommendations around stress management.
Okay, so stress, menopause, what's the connection? So the first things first, if one looks at the average age that a woman goes into menopause, which would be somewhere between 45 and maybe 55. Yes, there are younger women that have naturally had abnormal function of ovaries or some that had surgically removed ovaries. I'm not going to talk about it because that's too much of a unique situation. But for the average woman entering menopause, if you just take a look at that age, what's going on? It's basically, we've got the sandwich generation. You have young adult kids that maybe are still trying to find themselves. So that's stress right there. You have your elderly parents that you're trying to help them out. So by definition, that right there is major stress. And menopause just happens to be a physiological event going on with your ovaries, but your life circumstances are going on. So that's one important aspect to stress. Number two, as a woman gets into menopause, one thing that definitely starts happening, we call them vasomotor changes. So, for example, hot flashes, difficulty with night sweats, events like that, they interfere with a person's ability to sleep. Poor sleep can definitely lead to anxiety. So that's kind of that indirect connection. As far as the changes in the hormones, I did not necessarily see any official information in the literature, and this is just for me. There may be doctors in this session that do know it, but I didn't see any specific connection in terms of decreased estrogen equals kind of increased stress per se. Although, interestingly enough, the use of different types of hormonal replacement like estrogen or the combination estrogen and progesterone, that does seem to improve the symptoms of stress. So there's clearly some kind of connection between the changes in the hormones associated with menopause and the stress that a woman experiences. I think the couple of practical things. Number one, I think we should all agree the baseline is no human being, man or woman, no one should ever have to deal or live with anxiety just because it's considered to be just a fact of life. So that's first and foremost. And now the definition of anxiety disorder versus anxiety. I think it's fair to say anyone and everyone in this call and anyone that's physically alive, we're all facing some form of anxiety. It could be every hour, every day. That's more situational. That type of anxiety can actually be well treated by speaking with psychologists, utilizing techniques like cognitive behavioral therapy. That's one type. Then there's anxiety that's more of a biochemical neurotransmitter component. That type of anxiety would definitely benefit from medication, except that really needs to be done in conjunction with a mental health specialist, like a psychiatrist or nurse practitioner psychiatry, people that deal with this basically every day. So, but the important thing is to differentiate. Anyone with anxiety doesn't mean that they need medication, but the other way around, people that have anxiety, telling them just go do yoga or deep breathing, that's not going to work for everyone either. So it's really that combination and splitting it out. There's a lot to be said for also self-care, especially for women. I think most of us as men, we know how to take care of ourselves. It's very natural for us. For our females, it's not natural, especially at this stage of life, having taken care of somebody or multiple somebodies the whole life, taking care of yourself. It's almost like you don't even know what that means. So, one highly recommended approach is just to make sure you, for the first time in your life, maybe start taking care of yourself. Cut down on the guilt associated. Your As long as no one is sick and in the hospital and doing badly, but those elderly parents, they can probably wait that extra hour for you to go for that walk or to read that book that you find interesting. And your teenage or young adult kids, trust me, if you come an hour late to help them out, they're probably on their phone on one of the social media sites. They wouldn't have a clue that you came there an hour later. So take good care of yourself. No one else will.
That's a very good point for us to end on here. I think those are all of the questions that people from our community had written in with. I just want to make sure, though, before we wrap up, Dr. Katz, was there anything else on your list that you wanted to cover that we haven't gotten to?
No, I think we pretty much got to everything. I think the bottom line is just to understand that suffering is never okay. So there's some women that go through menopause and it's really not that bad. It's annoying, not that bad. That's fine. But then there are women that are suffering, and the two of them, if they're talking to each other, the one that's suffering could be made to feel really crappy because the other one says, I went through menopause. It really wasn't that bad. You're just not tolerating it. And that's just an immature situation. So if you're not feeling right, don't be afraid to get the help that will help you.
Amazing point. Whitney, anything from your end that we missed? Anything to
No,
wrap up with?
I mean, I just want to, anybody who's a patient or even a doctor, whoever is going through this transitional phase, it's very easy to be hard on yourself during this time. At the end of the day, it's likely not your fault. And to give yourself or learn how to give yourself grace and mercy throughout this and use this as an actual opportunity to learn more about you and your body, what you resonate with, what serves you, what's not serving you any longer. So this all comes down to just really self-care and taking care of yourself. So, meeting with the providers you need to meet with, getting in a community of women who are in the same spot, you name it, whatever level of support that you need, because at the end of the day, like I said, it's not your fault. So there's tons of things that are in the uncontrollables that that could be helped with a few different tools, so, and a few different changes. So, but I really thank you for this tonight. This was amazing.
Yeah, this was such a great session. Thank everyone on the call for taking time out of your evening to join us. We host generally 2 live events like this per week, primarily geared towards patients. So we cover topics ranging from hormones to sleep to protein planning to food tracking, exercise, anything and everything you can imagine around building a 360-degree lifestyle care program. So if anyone has any questions, our email addresses are in the chat window. Dr. Katz, check him out. It's drkatzweightloss.com. I saw a couple things come in here. Thanks for the time. Great. Yes, we will be sending around a recording, likely Thursday morning, that will come out. So be on the lookout for that. And I believe that that's everything. So, guys, any last words before we close?
Thank you for joining us.
Awesome. 45 minutes exactly. Thanks, guys. Have a great rest of your Tuesday, and we look forward to seeing you in our next masterclass. Thanks so much.
Good
Bye-bye.
night, everyone.
Bye.
Good night.